What is schizophrenia? Dr. Alam, he said the option is C, Eugen Bleuler. Any other options? C only. So the term schizophrenia was coined by Eugen Bleuler. So can anyone relate this one? Tell me, who is this scientist? Epstein. I don't know whether he is a scientist or not. So the other hint here it has given is a beautiful minds. So there is one mathematician who got Nobel Prize for his game theory, and what is the name of that scientist? So he is the mathematician who was given Nobel Prize in mathematics for his game theory. Why I have displayed this picture? Is it have any relation with the psychiatry, or more specifically schizophrenia? Because he suffered from schizophrenia. So you can watch that film, A Beautiful Minds. So we will start. So long back, Cherakai, he described patient with schizophrenia as gluttonous, the one who has increased appetite, filthy, walks naked, has lost his memory, and moves about in an uneasy manner. These are the brief symptoms or vague symptoms that have been described in the previous literatures. Then Dementia Praecox was given by Benedict Morel. Then Dementia Praecox was a term given by Emil Kraepelin. Why Dementia Praecox? So initially they thought schizophrenia as the disorder which is associated with memory problems, and its onset is much earlier. That's why it is that term was given as Dementia Praecox. Then, as I have already mentioned, Eugen Bleuler coined the term schizophrenia in 1911, and he also gave, the Eugen Bleuler only gave 4 years of schizophrenia. They are autism, ambivalence, loosening of association, and affective flattening. So we will see these terms. What is autism? Anyone? What is autism? Anyone who would like to answer? What is autism? So it is basically, autism is basically a self-absorbed life. Like the person lives in his or her own world. He doesn't care about the society, he doesn't care about others, he doesn't care about the environment. So that is what autism. So the children also, if you see, they live in their own lives, in their own world. So they are not concerned about other people, they are not concerned about other children. Even if other children comes also, they doesn't want to interact. That is what autism means. Ambivalence, as the term itself indicates, it is confusion whether to go for or not. So loosening of association. So this is one of the thought disorders. So during the thought, the person when he was speaking, the thoughts he was having, he was not able to display everything in a concise way. So there it comes loosening of association. It is one of the thought disorders. Then affective flattening. As the term suggests, there is a flattening of affect. There is no expressions. Or when you observe a patient, there are no significant changes in his expression. So that is affective flattening. So Eugen Bleuler, he gave these 4 terms, suggesting that maybe these 4 are related to the schizophrenia. Then Kurt Schneider, he gave 11 FRS of schizophrenia. What is FRS? What are FRS? F is first, R is rank, S are symptoms. So Kurt Schneider has given 11 first rank symptoms of schizophrenia. So according to Kurt Schneider, if the patient is having any one of these 11 first rank symptoms, we can say that the patient is having schizophrenia. So these are the first rank symptoms. 3 perception, 3 thought, 3 made phenomenon, 2 special phenomenon. So thought. The thoughts comes under audible thoughts, voices arguing, and voices commenting on one's action. So normally for NEET PG, NEET SS, many of the times you will read in depth. the prefrontal cortex, the genetics, the mutations and these things. But they will ask these things. How many first rank symptoms Schneider has given? If you know that number 11, then you will get 3 marks. So in those 11, what are those 11? Most of the times it will be asked. So audible thoughts. Audible thoughts are nothing but your own voices you are able to hear. So voices speaking, thoughts loud. So my own voices are speaking aloud. Then voices arguing. 2 or more hallucinatory voices discussing the patient in third person. So there are multiple persons. They are talking about me. Voices commenting on one's action, so voices describing subject's activity as they occur. So we can broadly separate or classify in first person, second person and third person. First person is my own thoughts, my own voices I am able to hear. They are first person, or we call it as audible thoughts. Then second person are voices commenting. There is one person who is directly speaking about me, or who is directly talking about me, that is voices commenting. Then the third one is voices arguing. There are multiple persons, more than 2 or more. They are talking about me, or they are doing something against me. So these are voices commenting on one's actions. So these are like perception, like I was able to hear those voices. Then according to, if we come to thought, there are 3 thought phenomena. Thought withdrawal, thought insertion and thought broadcast. So thought withdrawal. Thought withdrawal is, it is an active phenomenon. There is someone or there is some alien phenomenon. It is removing my thoughts. So whatever I am thinking, everyone is able to understand what I was thinking. Because there is some external agency or some external force who is removing those thoughts from me. Then thought insertion. Whatever thoughts I am thinking right now, they are not my own thoughts. They are being given by some other person or given by some other external agency. Then thought broadcast. Moreover, thought broadcast and thought withdrawal are same, but thought withdrawal is an active phenomenon. There is some external agency who is removing. Thought broadcast, it is broadcasting. Like passively everyone is able to listen. Then 3 made phenomenon, made feelings, made impulses and made volition acts. In the same way, made feelings. My feelings are not my own feelings. They are given by some external agency. Made impulses, the drivens are impulses that are being done by me. They are not my own, they are done by some other people. Made volition acts, again same, the actions and movements felt to be under outside control. Delusional perception, a private and illogical meaning attributed to a normal perception. So this is a very important one, delusional perception, which is considered as the first rank symptom, and also in ICD-10 it is one of the most important criteria also, delusional perception. So for example, I made some of you stand up and I asked them who coined the term schizophrenia. So that person may think that this is a normal phenomenon, because every time in the classroom the teacher comes, he or she will ask the questions to some people. But that person, he might be having schizophrenia, he attributes this perception to a different thing. For example, maybe sir, teacher, he wants to target me or he wants to spy against me. Maybe that is the reason why he made to stand up. Then somatic passivity. Subject is a passive recipient of bodily sensation imposed by external agencies. So all the somatic sensations that are in me are not mine. They are being given by an external agency. So that cap guy, please stand up. No, I will ask one question. Please, the last but one. So how many first rank symptoms Schneider has given? 11, very good. So what is audible thought? That's why if you listen, then you can understand. So audible thoughts are, my own voices are, I am able to listen. Okay, I am able to listen my own voices. Okay, it is not by some external agency or someone. They comes under made feeling, made impulse and made action. Okay, don't talk. Then somatic passivity, the subject is a passive recipient of bodily sensation imposed by external agency. So what is schizophrenia? The first question that is going to be answered in this slide. So in general, it is a fundamental and characteristic distortions of thinking, and perception, and by inappropriate blunted affect. So there are three things that comes in here. One is thinking, that is thought phenomenon. The other one is perception. The other one is inappropriated blunted affect. So if a person is having problems in these three phenomena, that is thought, perception and affect, then we can label the patient as suffering with schizophrenia. But the main important point is clear consciousness and intellectual capacity are usually maintained, although certain cognitive deficits may evolve in the course of time. The reason why I have shown John Nash is, even John Nash has suffered from schizophrenia, but he is the one who got Nobel Prize in mathematics. So the persons who are suffering from schizophrenia is not itself suggests that the patient is having poor intellectual capacity. So the persons will be having that clear consciousness and intellectual capacity, but if you delay the treatment, if you delay the course of duration of that disorder, maybe in future the person will be having some cognitive deficits. So epidemiology, if you see epidemiology, the lifetime prevalence of schizophrenia ranges from 0.3 to 0.7% and almost equal in both male and female age group. Male, it will be seen much earlier, that is 10 to 25 years of age group. In females, there are two peaks. One peak at 25 to 35 years of age, the other peak will be at more than 45 years of age. There are multiple reasons why there is bimodal peak in females. One of the reason could be due to stresses, one reason could be due to hormonal imbalance, but we can see bimodal distribution in case of females. Onset, there are three types of onset: childhood, early and late onset. So if the child is having schizophrenic symptoms within 13 years of age, then we will label it as childhood onset. Early onset less than 18 years and more than 45 years, we can call it as late onset schizophrenia. What are the types of schizophrenia? Of course, this is obsolete nowadays. No one is talking about the types of schizophrenia. In ICD-10 and DSM-5 they have mentioned. So the first one is paranoid. Paranoid is the most common type. Paranoid delusions and auditory hallucinations are prominent, but personality is relatively preserved. So the paranoid type of schizophrenia is the most common type, where the person is having some suspiciousness towards others. Maybe the other people are spying against me, maybe the other people are trying to do some harm against me. But here the most important point is personality is relatively preserved. There is no significant distortion in the personality. Then the other one is disorganized. The other name is hebephrenic schizophrenia, where the disorganized speech and behavior will be seen with a flat affect. Then catatonic schizophrenia, it is one of the most important schizophrenia where you are having the best prognosis, because the most common symptoms that you are going to see is motor symptoms. Even if you see catatonic schizophrenia, there will be echopraxia, echolalia, then will be posturing, mutism, waxy flexibility. So these are some motor symptoms that you will be seen in catatonic schizophrenia. Then simple schizophrenia, there will be predominantly negative symptoms. We will see what are the negative symptoms, and social withdrawal. Then tell me, what is von Gogh schizophrenia and Frost schizophrenia? Have that clinical postings of psychiatry, right? So when you come, you have to tell me what is von Gogh schizophrenia and Frost schizophrenia. These are the two MCQs that most of the times you will get. So what are the symptoms of schizophrenia? So one is positive symptoms, negative symptoms and disorganized symptoms. Positive symptoms, as you already know, they are delusions and hallucinations, combativeness and insomnia. Negative symptoms will be mainly affective flattening, alosia, anhedonia, amotivation, apathy, asocial behavior. Disorganized behavior includes disorganization in every aspect of the life. Either it can be thought, either it can be speech, either it can be behavior or affect. So a patient comes to me. The patient says, doctor, my wife is having insomnia. My wife is having suspiciousness that other people are talking about her. Okay. So I got a patient of around 35 years old female. Her husband complains that my wife is suspiciousness, that every time my neighbors are talking about her. So she lives in a village, and most of the times in villagers, that is a common phenomenon that maybe the other people are talking about me. Maybe the other people have done black magic against me. So that is a false belief. It is a firm belief. Okay, but the most important thing is that should be out of proportion to the social and cultural backgrounds. Okay, so culturally it should not be appropriate. Okay, so if you think that most in the entire village that is the same belief that this person is doing some black magic or this person is doing some doing something against everyone in the village, that could be a normal phenomenon. But we have to see whether it is normal and abnormal based on the social and cultural backgrounds. So every time if it is a false and firm unshakable belief, you can't label directly as delusion. You have to consider social and cultural background. Then hallucinations. What are hallucinations? They are false perceptions. With stimuli or without stimuli? With stimuli. Okay. So I am seeing this water bottle. This is green in color. Okay. So I think that this is not a water bottle. This is a snake. So there is stimulus. Can you label it as hallucination? This is a false. Okay. You are saying delusion? Illusion. So with stimulus you can call it as an illusion, without stimulus you have to call it as hallucination. Okay, that's why the first rank symptoms also, the first person, second person, third person, he is hearing those voices but they are not truly present. Okay, illusion is with an external stimuli you are seeing that distorted image, that is called called as illusion. In hallucinations there won't be any external stimuli, but you are able to get that perception. But there are many special hallucinations, functional hallucinations, reflect hallucinations. There are multiple special hallucinations where there are some exceptions also. So negative symptoms. So what are the negative symptoms of schizophrenia? So avolition, the total lack of motivation and the inability to perform any sort of goal, even something simple like doing a phone call. So evolution, like even the patient's presence to you, like even in initiation of the task also I am not having that interest. So that is what called as evolution. Anhedonia, inability to experience pleasure from social situations or activities like eating or other biological functions. So anhedonia is something where the person previously used to experience pleasure from those activities. Initially the person used to experience pleasure on talking to someone. Initially the person used to experience pleasure in having, in playing some games. Initially the person used to experience pleasure in reading books, but nowadays the person is not getting the same pleasure from those activities. That is when we call it as anhedonia. Social withdrawal, lack of interest in being with other people. And apathy, lack of feeling, emotions or interest that may show up as poor personal hygiene or lack of concern for yourself and others. Most of the times because of these negative symptoms only the schizophrenic patient presents to you in disabled, untidy, unkempt positions. Affective flattening, as we have previously mentioned, it is a flattening of affect that we will be seen mostly during the mental status examination. Alosia, difficulty speaking in part due to limited vocabulary. So when you are asking something also the person, so yesterday I got a patient. He was brought by his brother. Previously the patient was being shown to, I think, orthopedic, because the person is having some back pain. Even he was being diagnosed with, I think, cervical spondylosis because of his neck pain and other things. So the person doesn't have any other complaints. Okay. When I asked the patient, see, tell me what are your problems? He's finding difficulty in saying the words. He's able to say that he's not having any problem, but still he's having difficulty in expression of those words. Okay. So then later, when I asked the family member, his elder brother came, he told me that I haven't observed any symptoms because the person is previously an introvert and he doesn't speak much of the times. But when he goes outside, when he interacts with others, those people told me that this person is having, your brother is having some issues with psychiatrically, like he was not interacting the way he used to interact. So the first symptom that you can get is a negative symptom. But before diagnosing any psychiatric disorders, you have to rule out organic causes. So when I checked his neurological examination, it came to be as decrease in power and there is rigidity. So most probably he might have suffered with a small stroke, mild stroke. So I ordered for neurological investigations or radiological investigations. So once they come, and if we think that all the radiological investigations and blood investigations are normal, then we can go for the functionality, that is negative symptoms of schizophrenia. So what is the most heritable psychiatric disorder? This is the most common question you will be encountered. Like, if I am having this psychiatric disorder, maybe my children are also going to have this, or maybe my parents used to have this psychiatric disorder, I may be prone or I may be vulnerable. So any option? Most heritable psychiatric disorder? Schizophrenia. Then any other? That's why I have mentioned in an descending order. So the first option, that is autism. Autism is having 90% heritability. Okay, the first most heritable psychiatric disorders. Then the schizophrenia and bipolar, they almost share the equivalent proportion, that is 75%. What is ATPD? Last bench. What is ATPD? No one knows. Here no one knows. What is ATPD? Acute and transient psychotic disorder. The patient presents with the same symptoms like schizophrenia, but the onset is acute. And the prognosis is also very much better in case of ATPD when compared to other disorders. And of course, ATPD doesn't have that much genetic predisposition. So, what is the etiopathogenesis? It is a rough representation of etiopathogenesis, because whenever if you get any question on schizophrenia in medicine paper, there is no need to write everything in detail. You are not writing for an MD pass examination. So, you have to write everything in short, which are very much relevant. So, in case of etiopathogenesis, if you see the vulnerability model, most of the times the premorbid personality of the patient acts as one of the risk factors. There are some personalities, cluster A, cluster B, cluster C. Most of the times the cluster A patient, schizoid, schizotypal, paranoid personality patients, they are having the high risk for schizophrenia. Then individual social network and environment. So the persons who are having low social interaction, poor environmental network, maybe they are having the high risk factor. And neurodevelopmental model, as it has already been mentioned, most of the times if you see a pregnant females who are having some disorders, then during delivery maybe there are some obstetric complications, or after the birth there is neonatal hypoxia. Maybe these are the reasons for schizophrenia, but it is not a hard and fast rule that these will lead to schizophrenia. Genetic model, as I have already mentioned, schizophrenia is having 75% heritability. So there is strong genetic link. So one parent schizophrenia, the chances of children getting schizophrenia is 12%. Both parents, then it is 40. Dizygotic twins 12, and monozygotic it is 47%. So a patient with schizophrenia has prominent flat affect, alosia and avolition. Which neurotransmitter pathway is most implicated? So this is like the etiopathogenesis, like the neurobiology we are seeing. So there are few pathways that are implicated in the pathogenesis of schizophrenia: mesocortical, mesolimbic, then nigrostriatal and tuberoinfundibular. So which pathway? So what are these symptoms? That flattened affect, alosia, avolition, anhedonia, whether they are positive or negative symptoms? Negative symptoms. So these are negative symptoms. So which pathway leads to the negative symptoms? Because if you know these pathways, then you will be able to tell which leads to the positive symptoms, which contributes negative, and which leads to the side effects of the antipsychotics. So the nigrostriatal pathway that he mentioned, that leads to the side effects of antipsychotics. Okay, so we will see. So these are the 4 dopamine pathways of the schizophrenia. Okay, so that mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular or tuberohypophyseal. So the mesolimbic pathway, it starts from ventral tegmental area of the midbrain to the nucleus nucleus accumbens. Okay, so increase in dopamine leads to the positive symptoms in this pathway, that is mesolimbic pathway. They are delusions and hallucinations. So due to increase of dopamine in mesolimbic pathway, the patient presents to you with the positive symptoms. And mesocortical pathway, the pathway originates from ventral tegmental area of the midbrain again. It goes to prefrontal cortex. In prefrontal cortex, there are multiple areas: orbitofrontal cortex, dorsolateral prefrontal cortex, ventromedial. So each area leads to one of the negative symptoms. So decrease in dopamine leads to negative symptoms in mesocortical pathway. Then nigrostriatal pathway. Nigrostriatal pathway, substantia nigra to striatum, the main pathway that gives to the motor symptoms. Okay. So if there is decrease of dopamine in this pathway, that leads to extrapyramidal side effects and tardive dyskinesia. And tuberohypophyseal, from hypothalamus to the median eminence, if there is decrease of dopamine, that leads to hyperprolactinemia. Okay. So the answer to the previous question, which neurotransmitter pathway is most implicated? Mesocortical pathway, that is B. So initially we had antipsychotics like first generation, second generation. Nowadays third generation are also there. So first generation antipsychotics, the only mechanism of action is to decrease dopamine. Wherever they see dopamine, they will decrease dopamine. Either it will be mesolimbic, mesocortical, nigrostriatal and tuberohypophyseal. So the side effect of first generation antipsychotics are negative symptoms. So that first line symptoms will be decreased, but you will see significant negative symptoms in a patient with schizophrenia. Then nigrostriatal, there will be increased motor symptoms like tremors, rigidity, pseudo-Parkinsonism and tardive dyskinesia. These side effects will be seen. And tuberohypophyseal, if in case of male or female, there will be hyperprolactinemia. In case of females, there will be menstrual irregularities and bone deformities. These will be seen. So later we have the second generation antipsychotics where they will decrease dopamine in mesolimbic pathway, but they will try to maintain dopamine in all other pathways like mesocortical, nigrostriatal and tuberoinfundibular, so that there will be decrease of positive symptoms. But there won't be exaggeration of negative symptoms, there won't be an exaggeration of side effects associated with the antipsychotics. So that is the difference between first generation antipsychotics and second generation antipsychotics. That is a broad classification. So how do you diagnose schizophrenia? So we have two major classifications, that is ICD-10 and DSM-4 diagnostic criteria. Of course, now there is DSM-5 and ICD-11 also. So according to ICD-10, you need 1 month duration of symptoms. According to DSM-5, you need 6 months of duration of symptoms. So the symptoms includes the thought echo, the thought insertion, withdrawal or broadcast, passivity, delusional perception, third person auditory hallucination, running commentary, persistent bizarre delusion. At least if you mention one of those positive symptoms in course of 1 month according to ICD-10, and the symptoms lasting for 6 months according to DSM-5, to make the diagnosis of schizophrenia, you will get at least 2 to 3 months. There are other 2 or more features include, according to DSM-5, delusions, hallucinations, disorganized speech, disorganized behavior and negative symptoms. So the duration is very important, 1 month and 6 months. So if it is less than 1 month, the diagnosis would be ATPD, acute transient psychotic disorder. Then according to DSM-5, it should be at least for 6 months. So what are the major classifications that we will use in order to diagnose schizophrenia? The major classifications that we will use in order to make diagnosis of schizophrenia. There are 2 classifications I have shown you just now. ICD and DSM-4. So now new versions came, that is ICD-11 and DSM-5. According to ICD-10, what is the duration of the schizophrenic symptoms? Option A, 1 day, 1 month, 1 year, 10 years. 10 years, very good. So the option is, what is the option? 1 month. Differential diagnosis. So whenever any patient presents to you with schizophrenic symptoms, you have to see or you have to have this differential diagnosis. So the first most important differential diagnosis that you have to rule out is substance induced. It can be amphetamine, it can be alcohol, it can be cannabis. Most of the times I used to have patients most presents with cannabis induced psychosis. You will see exactly the symptoms resembling to schizophrenia. But if you ask them, if you corroborate the history with the family members, then you will come to know that there is some history of cannabis intake also. So the initial diagnosis would be cannabis induced psychosis. Then probably if the symptoms doesn't subside, maybe you will have to make the diagnosis of schizophrenia in later follow-up visits. Then there are other primary psychiatric disorders. So bipolar affective disorder, you have to differentiate it with schizophrenia. Then schizophreniform disorder, mood disorder with psychotic features. As I have already mentioned, there are few personality disorders, mainly belongs to cluster A. They make the person vulnerable to have schizophrenia, schizotypal, schizoid and paranoid personality disorders. Which of the following symptoms best predicts poor functional outcome in schizophrenia? So I want you to answer with, if the patient is having any of these following symptoms, then the prognosis is very bad. Option A, auditory hallucinations, B, persecuted delusions, C is negative symptoms and D is disorganized speech. So the first two are positive symptoms. The third option is negative symptom and the fourth one is disorganized symptom. Anyone? So which of these symptom gives the poor functional outcome in schizophrenia? So the option is C, negative symptom. So the negative, if the patient is having negative symptoms, that suggests that the patient is having very poor prognosis, because even with the treatment, the outcome will be very bad. Like we can't expect 100% recovery from the patient. So we have that prognostic factors. There are some good prognostic factors and some bad prognostic factors. Marriage, whether marriage is a good prognostic factor or bad prognostic factor. I think I didn't mention here. Okay, tell me. Someone got married. There are two patients. One is 35 years old male, the other one is 35 years old male. One is married, the other one is unmarried. So which of the patients are having good prognosis and which of the patient is having poor prognosis and why? Option A or B? A is married, B is unmarried. Married, why? But I thought you will say unmarried. So getting married is itself a good prognostic factor. Why? Because the first reason is being there are some family members who can take care of the patient. Okay, that is one thing. The second thing is the person himself is having some responsibilities. The compliance to the medications will be somewhat good. Okay, the most important being the family members are there to take care of the patient. So getting married is a good prognostic factor. Then onset. Late onset is having good prognosis, early onset is having bad prognosis. Females are having good prognosis when compared to males. Marriage, as I mentioned, getting married is a good and not married is bad. Onset acute and is having good prognosis, and slow and insidious are having bad prognosis. And precipitating factors. There are two patients, both presented with the schizophrenic symptoms. The first patient is having some precipitating factor, like there are multiple stress factors in the family, there are multiple issues in the family. The second person doesn't have any those precipitating factors, but he presented only with pure schizophrenic symptoms. So the first patient is having a good prognostic factor. So if we remove the precipitating factors that we think they are causing schizophrenia, maybe removing those schizophrenic symptoms, precipitating factors would lead to relapse of the remission of the schizophrenia. Symptoms, the positive symptoms are good prognostic factors and negative symptoms lead to negative prognosis. Subtypes, Paranoid and catatonic schizophrenia are having good prognosis. Epiphania and simple schizophrenia have bad prognosis. So last slide, please. Management. So management of schizophrenia is not limited only to the pharmacology. So getting a patient in the OPD and giving just medications and seeing the patient in follow-up is not the end of the treatment of schizophrenia. So the main goals and objectives of treatment is, of course, the obvious reason will be decreasing symptoms of schizophrenia, improve the quality of life and socio-occupational functioning. So the person, after getting recovered from the symptoms, the person has to go back to his work, the person has to go back to his previous social and occupational functioning. Prevent relapse and hospitalization. So there should be a good follow-up. Once the patient gets improvement of the symptoms, the person has to come for the follow-up, and there should be no relapse and hospitalization. Minimize adverse effect of medication. So based on the patient profile, based on the side effect profile, you have to suggest one medication which should be causing least side effects for the patient. Then you have to decide whether OPD or IPD basis. When do you admit a schizophrenic patient? When do you treat the patient on OPD basis? So there are certain indications which we can say that is the we can admit the patient. So presence of suicidal behavior. If a patient of schizophrenia presents with suicidality, then we can admit the patient. If there is presence of severe agitation and violence, then also we can admit. Refusal to eat. The person is not eating for the last few days with severe malnutrition, unable to take care of self. Of course, catatonia and comorbidities. If the patient is having other physical comorbidities, we have to admit the patient. So the main indication will be creating trouble to self or creating trouble to others. Okay. So the self is not eating, severe malnutrition, to others include severe agitation, violence, and these things. So if the patient presents with any of these indications, you have to admit the patient. So pharmacological management include antipsychotics, first generation and second generation. APA guidelines recommend use an atypical antipsychotic or second generation antipsychotic. The sole reason will be due to less side effects. The third will be patient's preference and previous response. So before choosing an antipsychotic, normally what the Western studies says, you have to give a basket of medications to the patient. See, these are the medications or these are the therapies that are available for you. Now you have to decide which of the treatment or which of the therapy you would likely to opt. But you have to give the complete psychoeducation to the patient. The benefits, the advantages, disadvantages of each and every medication. Then the patient has the right to choose the medications. And of course, previous response. In the family, if the father was having schizophrenia and he was responded with haloperidol, then high chances that you have to start the haloperidol in the family members also. Or the patient had a previous good response with haloperidol and stopped medications and there was again relapse. You can't suddenly go to the other molecule. You have to start with haloperidol again. So these are the antipsychotics, first generation and second generation. First generation includes chlorpromazine, thyroidazone, which are not using nowadays, but of course chlorpromazine we are using as sedative agent. First generation flufenazine, haloperidol, pimozide, thiofluoperazine. Second generation aripiprazole, clozapine, quetiapine, olanzapine. So the side effects of antipsychotics most commonly seen with first generation, but of course high doses of second generation can also lead to EPS. So they include acute dystonia, akathisia, pseudo-Parkinsonism and tardive dyskinesia. Acute dystonia is a medical emergency. The patient presents with acute muscle spasms, sudden muscle spasms that primarily occur in the eye, neck, face and throat muscles. Management solely includes anticholinergic medications, or you can decrease the antipsychotic dose. Akathisia, there will be inner restlessness. The patient can't sit at one place for a long time. The patient says that there is some inner restlessness that has been happening. So management include again same reduction of the dose of antipsychotic or add a beta blocker, preferably propranolol. Pseudo-Parkinsonism, as it is medication-induced Parkinsonism, the name itself says pseudo-Parkinsonism. Again, the patient presents with the same symptoms resembling to Parkinson's, tremors, rigidity, then akinesia. The rigidity would be mainly cogwheel, mask-like faces. Management will be anticholinergics. Tardive dyskinesia, these are the movement disorders, mainly affecting the facial muscles, tongue chewing, lip smacking. There are multiple variants of tardive dyskinesia there. Management includes vitamin E and tetrabenazine. So duration of treatment, many of the times you will get these questions from your outpatient department patients. So I have been using these medications since the last few months. So when should I stop the medications? The answer itself comes from guidelines. According to APA, the first episode, the patient has to continue the medications for 1 to 2 years. Multiple episodes, the direct answer will be more than 5 years. But if there are associated suicidality, if there are associated with multiple relapses, violence, agitation, then the answer can be lifelong. So the last slide, that being non-pharmacological management. So as we have previously mentioned, the management of schizophrenia is not only limited to pharmacological, but non-pharmacological management comes into play, because we want the patient to go back to his previous life. We want the patient go back to his previous cultural society. We want the patient to go back to his previous occupation. We want the patient to work productively like he used to do before. So social skills training, because there may be some significant negative symptoms, the social skill training will be effective for those patients. Family oriented therapy, because the family doesn't know what is the disorder, how many days the patient has to use the medication, what are the symptoms, how to tackle those type of patients. But of course there will be expressed emotions, or burnout will be seen mainly in caregivers of the schizophrenia patient. So you can have psychoeducation and you have to control those expressed emotions. Individual therapy, help in interpersonal relationships, mainly in case of married males and females. Group psychotherapy encourages skill development, and rehabilitation. Rehabilitation is specifically including if the patient is already previously working in a certain institution or certain occupation, we can get back the patient to the same occupation. But if the patient is not at all working, so we can give some rehabilitative treatment. For example, we can ask the patient what are his interests, what are his habits, what are his hobbies. So based on his hobbies and habits, we can bring back the patient to his occupations.